welcome to our provider forum. My name is Molly and I am the grant specialist at the Breast Cancer Resource Center here in Austin. We have a very full agenda today and I want to give our presenters as much time as possible to share their slides and answer all of your questions. So we'll go ahead and get started.
Hi, everybody. I am Rayanne Evans, and I'm Executive Director of Breast Cancer Resource Center. We are so delighted to have you with us today, that you've chosen to spend this hour with us, and we hope you'll find this time well spent. BCRC has been providing patient navigation and support services to Central Texans with breast cancer for 26 years. And in addition to patient navigation, BCRC also has multiple monthly support groups based on age, stage, primary language. And in 2020, we began our first support group for Black women called Pink Table Talk. Just last month, we started an informational class for women who are newly diagnosed with breast cancer. And over the last year, during the pandemic, we have spent a lot of time building a robust video resource library that you can refer your patients to, or that you may go to find some really good information. And many of you are already partners with BCRC, and we are so grateful for that. But I did want to let anybody know who's interested in learning more about us that you can go to our website at bcrc.org or call our helpline at 512-524-2560. I'm delighted to tell you that in late 2019, BCRC was one of 8 grantees awarded a collaborative grant by the CDC. And this grant is specifically geared towards young women with breast cancer and young women with metastatic breast cancer. And it's designed to help improve services for us and our providers and to identify gaps where there is not enough information being shared. So today is actually a culmination of several months of work by both BCRC staff and our partners. I do want to acknowledge the staff that has worked so hard on this needs assessment. And first I want to acknowledge Molly McAdam, who's our grant specialist, who you met earlier. Sharon Malatok is our Chief Program Officer, and Elaine Gonzalez is our community educator. And they have all done an amazing job, and we are so excited to share our findings with you today. Now, I would like to introduce you to our presenters for today. Doctors Heather Becker and Deborah Volmer-Dalkey will be sharing information about our needs assessment. And then Dr. Catherine Hudson will share how she addresses some of these findings in her everyday practice. So Heather, take it away.
Thank you, Rayanne. Molly, are you going to change screens, or shall I just get started? I think maybe I ought to just get started in the interest of time. We conducted focus groups and interviews last summer. And as you can see here, we did 12 key informant telephone interviews with primarily nurse navigators, although we also had social workers, physical therapists, and genetic specialists. And they were asked about their perceptions of existing services, barriers to services their patients face, concerns specific to young breast cancer survivors, and kind of what would be in their perfect world available to people. And we also did focus groups. We did 5 of them with the groups that are listed here. And in total, there were 33 women, some still in treatment, but others who completed treatment up to 10 years ago in those focus groups. And they were asked about the sources they use for information, the services they wish were available to them, the barriers they've experienced, and their communication and relationship with their providers. Molly, can you go to the next slide, please? So first, looking at what the key informants told us, and this is a quote from one of them, and it is so true. They do so much to try to help breast cancer patients through the often confusing and complicated journey. how their referrals work, a lot of them are referring people out, but it varies by the organizations they're with. And even within an organization, different geographic locations may handle that differently. A few providers discuss delays in care for Black women or language difficulties for some Latina women. They also talked about their myths out there, possible that can affect the treatments and create problems in terms of communication, of course. They recognize the special needs that this age group has, particularly around children, childcare, and their spouses, and as well as issues around body image, sexual image, and so a lot of special issues for this age group. They provided numerous examples of going above and beyond to get women's services, but what they really want is a world in which coordinated, affordable care is tailored to the individual and provided by an interprofessional team. I would call your attention to the comment, we often think that people who live in rural areas are disadvantaged relative to people who live in more urban areas, and they certainly have transportation challenges to get to services. But as one of the navigators who works in a rural area pointed out, there's some things about rural areas that are real advantages. She can reach out and get help from churches who will provide economic assistance, for example, to pay people's utility bills, or people that will provide scholarships for the children of breast cancer survivors. So this quote is from her, and I think it's good for us to remember that. Could we go to the next slide, please, Molly? One of the things that most of the navigators, excuse me, and other key informants talked about was this need to think comprehensively about the needs of the young cancer survivors. And here, I think these two quotes illustrate this well. They recognize that this is a new way of thinking for many oncologists who have been traditionally focused on the medical treatment and symptom management. But particularly for this age group, you really need to think beyond those more traditional boundaries. Next slide. So turning to the focus groups, women need the right information at the right time. And sometimes it takes multiple attempts to get women engaged because particularly when they're initially diagnosed, they're just so overwhelmed that it's difficult for them to respond to some of the efforts that are being made to reach them. But in addition, some of the women discuss delays in getting diagnostic testing, such as mammograms, because of their age. Others, many concerns about their children and their spouses, and the effect this was having on their children. And so grateful for services that are available in our community, such as Wonders and Worries. But one woman said she'd been on the waiting list to get services for a child for months. So not, even though it's a great service, it's not always accessible to people. Women perceive that their providers may be uncomfortable discussing certain issues with them, and particularly around fertility preservation or pregnancy after treatment, issues around intimacy and so on. They feel like the providers weren't comfortable in those topic areas sometimes. As we mentioned before, we did specifically have focus groups with Black and Hispanic women and asked them specifically if they thought that there was anything about their race or other aspects of their background, if they lived in a rural area, whatever it was, that might be affecting the care they were receiving. And one Black woman described what she called race-based nonchalance. There was a sense that Black women maybe aren't hearing the same messages that their white sisters hear about treatments from the providers. I will say on the provider side, some of them are concerned about bringing up issues like genetic testing because they know how costly that is. But sometimes that feels to some individuals and groups like they're being left out and they're not hearing the same messages. And the woman who talked about the race-based nonchalance said that a Black nurse actually stepped in a couple of times to try to correct that situation. Throughout the focus groups, there was a lot of concern about financial issues, as you can imagine. And even for women with insurance, there are all the hidden costs, or even understanding how to apply for various kinds of assistance. But the hidden costs not covered by insurance create great hardship for people. Next slide, please. I think this woman's comment at the top really illustrates well what it is that the women are going through, particularly women in this age group. One woman suggested in the first meeting, oncologists discuss what questions are most appropriate for each type of provider. What should they ask of primary care providers? What should they be asking surgeons or radiologists, so they know kind of who to go to with which questions? One of the real difficult transition periods for people is when active treatment is over and that intensive support they've had from the team really diminishes and they really feel kind of dropped. And I would call your attention to this last comment. This woman went in for her first follow-up checkup, I believe, or a 6-month checkup, and she just started crying uncontrollably. Just as she says here, it all came crashing down. Another woman described this as PTSD. Luckily, the provider of the first woman was able to get her mental health services, get her a referral, and get her the service that she needed. But I can't overestimate how important and how often it came up that time when the active treatment is over is a very difficult transition for a lot of people. Next slide. As we mentioned, we had one focus group with women with metastatic cancer, and I really appreciate this analogy that one of the women had. She said, you train differently for a sprint than you do for a marathon. And so what we need is someone to help us train for the marathon that we're in. They want information sooner, to be educated sooner about the differences between recurrence and metastasis, what to look for in terms of signs and symptoms, conversations about palliative care and planning for end-of-life care, and not at the end of life, but earlier on. The financial burden, as I mentioned, everyone mentioned that, but for those with metastatic cancer, it's just devastating because it goes on for so long. And so they really need help with financial planning. Next slide. So take-home messages for us when we try to pull together the information we heard from both groups, the key informants and the women in the focus groups, is certainly the better coordination of services, particularly after active treatment. Sometimes services that everyone had the sense that there's good services in Austin, but sometimes there's lack of awareness, or they're offered at times or places that are not convenient for people to take advantage of. So there's a sense of the services that are out there that kind of fragmented, difficult to navigate, they come and go. As we mentioned before, financial burden is mentioned by everyone. What was kind of interesting is going into this, because of the age group these people were in, we had an expectation that they would be trying to get a lot of information online. Actually, that turned out not to be the case for the women in the focus groups. They really want the information from their providers, either their oncologists or navigators. They want it from trusted sources. They are wary about what's out there on the web. And so they really want that somebody, a really credible source of information available to them. Both groups talked about the importance of communication, although in somewhat different ways. Sometimes the key informants would talk about health literacy issues and concerns. Women never, in the focus groups, never use that language. They want, most of them want as much information as they can get. And they recognize in different formats. For some of them that a binder with all this information, great. Other people, no, they want a person kind of explaining things to them. But all of these conversations really pointed to the incredibly important role that navigators continue to play in providing and interpreting information and supporting and empowering survivors, in some cases to push back or to ask for more information. One woman described her navigator as my #1 light source of truth and source of information. And in conclusion, I would draw your attention to this last point on the slide. We're asking these women to make incredibly important, life-changing decisions about fertility preservation or treatments or all kinds of things, as you all know, at a time that is so difficult for them to make these decisions because of the stress they're experiencing. We know that stress has a negative impact on cognitive functioning. And so what tends to happen is people, they kind of almost develop sometimes tunnel vision. They're trying to, they can't take in all this information at one time because they are so stressed. So they narrow down what they're looking at or thinking about. So that really affects their decision-making. And if you think about the age these people are, for many of them, the most important decision they've made up to that point is what to do after they leave high school. And now, we're asking them to make decisions that, again, are really life-changing decisions at a time when they may be least able to process this information to make good decision and good choices, because we're also telling them they have to make the decision pretty fast. So anything that you all can do in terms of repeating information to people, kind of breaking it down into smaller pieces so that maybe they can process it more easily, are really going to be important for this group. And now I'd like to turn over to Deborah Dahlke, who is going to talk to you about the survey.
Thank you, Heather. So the questions and the areas of concern that Heather discovered and uncovered in the focus groups were formative for us in developing the survey. We launched an online Qualtrics survey late in 2020. And I think as we go through these, both Heather's comments and mine, I think it's important to realize that these questions, these responses occurred during the time of COVID. So the extent to which that factors in will always be unknown, but I think that we'll likely see a continuation of virtual care. So just keep that in mind as we go on. Both the survey and the focus groups were considered by the IRB and considered exempt. We conducted the survey over about a 2.5 month period late in fall of 2020. We distributed it to healthcare providers, Breast Cancer Resource Center networks and clients, nonprofits, Cancer Alliance of Texas, and members from or groups from our CDC advisory group. The participation was actually pretty good. We had a provider survey, the participation in that was low, and I'm not included it in this report. But for the patient survey, we had a total of 126 completed surveys. Of those, 30 were completed by women under 45. The average age was about 42. And then we had 80 women diagnosed beyond age 46. 16 of the surveys did not include their date of birth or their age, but they completed all the questions, so we were allowed to include them. Next slide, please, Molly. So the groupings of questions also kind of followed the work that Heather and the focus groups did. So our first group was about what concerns breast cancer patients most. The scale was from 0 to 100, with 0 being least concerning to 100 being most concerning. And if you look at the left-hand column, that's all of the participants, all of 126 of those. And it's kind of the expected areas of highest rating were fear of cancer, returning side effects, reconstructive surgery, understanding health, insurance benefits, mastectomy, managing pains. All of those were pretty high in the 70s. The second column on the right is those patients under 45. And again, it makes sense kind of cognitively when you look at their age group. Their concerns were greater than the older patients around maintaining employment, fertility, emotional support for kids, and even keeping up with coursework. Next slide, please, Molly. So the next area, or the grouping of questions, were around the need for how helpful the healthcare team was in terms of providing assistance to the, and remember, this is the entire healthcare team. And so what we've got here is a comparison of the older women, those over 46, to the younger women. And on average, the younger women were about 16.6 points lower. So there's a significant difference in what was important to them. Among the greatest areas of difference were lack of energy, having financial resources, ability to relate to my significant other. But I think it's important to note that for all of the women, in this area, most of the points of even of the older adults, the older women, were in their 50s and 60s. So they didn't rate their healthcare team as incredibly helpful in this area. And so again, these are more socio-economic dynamic areas rather than areas of care, but important to realize that these are the things that the women feel the need for greater assistance. Can we have the next slide, Molly? So younger women also felt less supported during the transition for care. Again, this was an area that Heather brought up as, and most oncologists and care providers in oncology know that this is a difficult time for women to transit out of care. Again, the scale went from 0 to 100 with no discussion to 100 to an in-depth discussion. And when I looked at this, again, it was during time of COVID. Also, these women are still under stress. And so, whether or not they were actually discussed or they just didn't hear, we won't ever know unless we go a little bit deeper. But I think it's important to see again that there was a significant difference between the younger breast cancer patients. On average, they were about 17.8 points lower than the older women. The areas with the greatest difference were around long-term treatment effects and what to expect, how frequently to have scans, and the need for financial services and counseling and support. Again, if you look at that, there are areas where all of the women felt less supported, including need for financial support, counseling, and the need for ongoing mental and emotional support. So this clearly, again, echoes what we found in the focus groups, that there is a need for this kind of care overall for the healthcare team. Next slide, Molly. So our key takeaways, I think it's important to realize that, our research around Texas women and Central Texas women, primarily younger versus older, it really echoes and finds agreement as concurrent with the current field of literature in AYA or young breast cancer patients. These patients are at risk for emotional and psychosocial sequelae during and after treatment. There was a 2014 retrospective survey that age matched both healthy controls and younger women. And they found that the younger women, the younger patients, had long-term issues with emotional and social functioning. And also that younger women, younger breast cancer women, had lower vitality and higher rates of depression, both during and after treatment. More recently, there was a 2018 study of young breast cancer patients. And these, again, it echoes the concerns that Heather found in the focus groups. The concerns were around fertility, sexuality, body image, disruptions in relationships, as well as financial and emotional concerns. So the key takeaways are quantitative analysis are concurrent both with our focus groups and current research, that younger women diagnosed with breast cancer require age-specific and additional psychosocial support, and that includes financial as well as emotional and mental support. Ideally, these would be coordinated by multidisciplinary care teams, which many of our providers do have. At US Oncology is an example. They have social services, they have financial services. And so with that, I'll turn it over to Dr. Hudson, and she'll be talking about some of the things that are available to the patients. Thank you again for letting us share with you.
Hi, everybody. Good afternoon. Thank you to the BCRC for having me today. I'm so grateful for the chance to talk to fellow providers and practitioners here in Austin who are passionate about excellent breast cancer care here in Austin. So this work is really important in highlighting the needs of the survivors in our own community so we can learn how we can better serve them. So I want to thank the BCRC for undertaking this important work because it allows us all to do better. Today, I'm going to talk about how to address many of the concerns brought up by the survey in my approach to caring for breast cancer patients. I'm a medical oncologist. I'm at Texas Oncology in Central Austin. I'm also the Director of Survivorship and Dietary Services for Texas Oncology. So I have this visual here that shows that breast cancer care is much more than just therapeutics. Oh, in the old days, 20 years ago, physicians, oncologists thought of breast cancer treatment or breast cancer care really as a treatment, medicine, surgery, and radiation. And I'm really focusing on early stage breast cancer here, not metastatic breast cancer. But the research in the past has really focused on treatments and their effect on survival, not taking into account other important measures that are really important to patients, such as quality of life, fertility, overall health and well-being. And in the past 10 years or so, there has been a renewed focus on the entire patient and wellness in clinical trials and also in the practice of oncology. So this is a good thing. And this really is what survivorship is, incorporating symptoms, overall health, patient goals, and quality of life into breast cancer treatment. So we in the oncology space really have to look beyond just the treatment, and that is really important in our care of breast cancer patients. And this is also where the art of medicine comes in. Next slide, please. So in thinking about the survey data and the forum data, I separated it into two main buckets, the way I thought about it. So the first group is the concerns at the time of diagnosis and while survivors are going through therapy. And then the second, main bucket is in that survivorship period. Now, technically, all breast cancer patients are survivors from the time they're diagnosed. But when I'm talking about survivorship here, I'm really talking about after their active treatment. So at the time of diagnosis, these are all of the concerns that breast cancer patients have. Look at how overwhelming this is. And from the oncologist's perspective, we're focused in the upper left corner, right out of the gate, thinking about, should this patient have chemotherapy? What about radiation? What kind of surgery, reconstruction? A whole lot of doctors are involved right from the beginning, which is how it should be, but it's definitely overwhelming. We as oncologists and providers in the beginning need to remember all these other things that are going on as well. It's important that we all think about genetic risk of the patient. Does the patient need genetic testing? The patient is worried about their fertility. So it's very important that we bring this up with every patient who is premenopausal. We have to think about the patient and their overall, in the context of their overall health, their mental health and sexual health as well. And the patient is worried about what the long-term effects of treatment and cancer will be. And also, what's the risk of them dying from this? This is something that patients all think about when they're diagnosed. And then there are all the social concerns. How is the patient's life going to change? Their kids, with their partner, financial concerns. What about their job and school? And so on. So it is a lot. And it's a lot to go through at the time of diagnosis in visits, but it's really important. So I'm going to talk about how I think about this in my care of breast cancer patients. Next slide. Okay, so how can we better address patient concerns at the beginning? So communication. And in most cases, patients are really overwhelmed at this time. And that's been mentioned several times today. And when one is overwhelmed, it's really hard to think about decisions and make sure a patient is making the best decision for themselves. So it is critical to always include or invite a support person to be part of the visits and to help the patient with these decisions. Hopefully it's a trusted friend or family member. If someone comes without a support person, then that usually is a sign to me that that person is going to need more support, and that's when a navigator can really help. So we thank the BCRC for that. It's important that we providers communicate with other involved providers in our busy life. That can be hard sometimes, but it is important to go that extra mile to pick up the phone or track down the other providers involved. And then especially if a patient is really overwhelmed, I like to give the patient more opportunities to work through these decisions and discussions. And so if someone needs more frequent visits, then fine. They can come back several times until we make the treatment plan or until they feel more comfortable. So we also need to make sure we address each potential area of concern, and that is on us because of certain taboos, or maybe the patient is uncomfortable. They may not feel comfortable bringing up, their sexual concerns or finances. And so it's important for us to make sure we ask about these things. I bolded fear there because I think, having breast cancer is scary. There is no way around that. But in some cases, that fear can spiral. And what we don't want is fear to be the reason that the patient is not making decisions in a healthy way. So we really need to address that out of the gate. And then ask about anxiety and sex. It's very important that we ask about fertility unless the patient is postmenopausal. And there are studies that show that this is something that gets forgotten a lot of the time. And so we need to make those appropriate referrals. This can also be a really difficult thing for young women to wrap their heads around when maybe they hadn't thought about if they wanted kids or if they wanted more kids, or they hadn't talked with their partner about it. So that can take a lot of discussion. We need to ask about financial barriers and social concerns. I think at most of the centers here in Austin, every patient has the opportunity to meet with a financial counselor. But we also need to bring that up during the visit. And then it's really important that we express empathy. I'll tell a little patient vignette real quick. I had a patient who actually didn't have breast cancer. She had a different type of cancer, and she had met with multiple other oncologists when she was first diagnosed. And I met with her, and we were just talking through everything. And I think I said something like, I'm really sorry this is happening to you. And she said to me, thank you so much for saying that. I've met with all these other providers and no one has said that. And just those simple words, means a lot. And so I'm not saying that to toot my own horn, but I was surprised by how just that one short little statement that I made, meant a lot to her. And so that's something I really try to do often, just for that reason. It's so easy to get bogged down in all of the decisions that need to be made for treatment. And then with all of this, this is a team-based approach. There's not one provider who can do all of this and provide all of this support. So navigators are really important, support groups, social workers, financial counselors, and our fertility partners. One interesting take-home message of the survey and the focus groups for me was that patients want to hear about these topics from their provider. I think that's really especially clear with the financial stuff. Most patients are meeting with financial counselors at some point, but they still feel a greater need to discuss it with their provider. So that was really fascinating to me. And so I don't think that means that they expect us to be experts in insurance. I certainly am not. But I think they want us to acknowledge it and help guide them the best we can. Next slide. Okay. So complex and shared decision-making. Shared decision-making is really important. This is not the old days where an oncologist said, you will have chemotherapy and you will have a mastectomy. There are a lot of choices, and each patient needs to make the best decision for themselves. So what can help a patient make the best decision? And it's very important that we providers provide clear, unbiased medical evidence. So a lot of what we do is based on data. And so we need to present that data to our patients so they know the risks and benefits of different alternatives. We should never give just one choice. We should say, if you do this, this is what we're looking at. If you do this other thing, that's the risks and benefits of the other option. Clinician expertise and communication, tailoring the evidence for the individual patient. There are some tools that really come in handy with tailoring to the patient. So For example, in early stage hormone positive breast cancer, the Oncotype is a great report that tailors treatment or chemotherapy to a particular patient's tumor. There are some online tools. UK Predict can provide nice visuals to go over with the patient. And I know plastic surgeons also have some tools in helping make decisions between some type of reconstructions as opposed to others. Also within decision-making, it is really important to talk about what the patient's goals are. You know, everybody's different. And so that can really help clarify certain decisions. And then education is really key. So it was brought up earlier that some women came away with the impression that they were not getting adequate treatment as compared to some other friends that were going through the same thing. And so I think it's important to emphasize that it's not one size fits all treatment. Different women have different cancers, have different characteristics and goals. And so their treatment plan is tailored to them and their tumor characteristics. It's also important to talk about the overall goals of therapy. And what goes hand in hand with this is the definition of recurrence and metastatic disease. You know, the end goal is to keep our patients healthy. Of course, the treatment is not easy and people can feel sick through treatment, but our overall goal is to keep women healthy and alive for as long as possible. And so one thing that came out in some of our focus groups is what the definition of recurrence is. And when we providers talk about recurrence, we are thinking metastatic cancer, which is incurable. And that there is a disconnect for a lot of patients because that does not translate to the patient who think of recurrence as not metastatic disease that is incurable. And so especially in talking about chemotherapy, it's important to say, you know, we're doing all of this stuff to help prevent recurrence and metastatic disease and hopefully cure you. And so some of that lingo is important. Okay, next slide. And so after the patient completes their treatment, we're transitioning to the survivorship period. And at this time, there's a new set of concerns. There's a lot of overlap, but they've made it through the hard physical part. And this is when all these other things come to the forefront. So emotional, psychological health, fear of recurrence hits pretty quickly. Focusing on overall health and wellness, functional recovery. I should also put in cognitive recovery if there are some cognitive effects, sexual health, long-term side effects, the financial issues can still be there, family issues, fertility, body image, what to expect, what screening will happen, another common thing that came out is patients feel like they don't know what to monitor for, what symptoms they need to watch out for as they go along. So next slide, please. So this time right after treatment is completed, at the beginning part of the survivorship period is known as the greatest time of distress for survivors, and that's backed up with clinical research. This is when anxiety and depression tends to be the worst, believe it or not, which is very surprising often to survivors and also to all of us because we think, yeah, you made it. Everything is going to be great now. You're going to feel better. But everything kind of hits them. And a lot of women start to process all of what has happened emotionally, you know, right at this time. And it's also when a lot of the frequent visits stop. Or at least they're less often. And so a lot of the support that they were getting just from coming in to the office or having, you know, telemedicine is not there as much. And that can feel like a hole for some patients. Some patients can feel abandoned. And the other thing that happens is that a lot of women expect to just go back to their prior selves. So I think it's important to remind them that there's a new normal and that no one can go back to the way that they were before going through breast cancer. You know, it changes somebody and in multiple ways and not always for the worse. So it's important to acknowledge that and give realistic expectations. So some women need more frequent visits during this time. And that's okay. And the other thing that is great to address all these concerns is a survivorship visit. And this is something that all patients should have available to them. So I encourage all of you, as being on this call, if you come across a patient who's in this period and struggling with some of these things, or even if they're not, ask them, hey, have you had your survivorship visit? Because this is a visit that that we can do in the office, and that I certainly encourage for all of my patients, to readdress all of these things that is going on with them, reevaluate what they've been through, gives us an opportunity to really focus and ask about, their mood, their sexual health, how are they recovering functionally? Do they need to see physical therapy or a dietitian or a counselor? So that survivorship visit can be really valuable. And the other very important thing in the survivorship period is focusing on a healthy diet and exercise. We have very good data that exercise, even independent of weight, can really help prevent breast cancer recurrence and hormone positive breast cancer. And so, this is what I tell my patients: if we could bottle up exercise and turn it into a pill, a pharmaceutical company would make billions of dollars off of it, because it is really really good stuff that can help prevent recurrence of breast cancer. This period is also a good time to reassess survivor goals. What are their goals for the rest of their life and for overall health and wellness? It's a good time to remind the patient about risk of recurrence, what recurrence means, what I was just mentioning, what symptoms to look out for. And especially that if they have any of the alarming symptoms like shortness of breath or pain in one part of their body or a cough that doesn't go away, to really make sure they are coming and telling us about it, rather than, or in addition to going to their primary care doctor, because we might pick up on recurrence sooner than we would otherwise. And this is also the time that a patient needs to reconnect with their primary care doctor and other parts of their care team. And we need to tell them, with what complaints or issues do they go to which doctor, and try to have that team approach. Okay, next slide. Okay, so as highlighted in the surveys and the focus groups, young breast cancer survivors need some more support. There are higher levels of anxiety and depression, long-term consequences. So it's really important that we address these things. So again, I really encourage more frequent visits if that fits with the patient's goals, because it gives them more opportunity to talk through these things. It's really important to address fear of recurrence. This is something that everybody goes through. There's no magic wand to take away the fear of recurrence, but there are some good tools to help manage that. And it does tend to improve with time for most people. Important to encourage patients to prioritize their health and mental health, especially for our young women who are mothers, who are pulled in many directions. They really need to take care of themselves. And then refer to team members in the community as needed. And also the great support groups that we have available. So I wanted to highlight, since this is a forum for other providers here in Austin, that we have really great community partners here in Austin that are doing a lot for our cancer patients, especially our breast cancer patients. So BCRC, of course, is fabulous with support groups and counseling and navigators. And I always encourage my patients to seek out BCRC. Other organizations that can help with counseling include Flatwater. The Patient Advocate Foundation can help with financial concerns. Triage Cancer can help with financial concerns. Regarding Cancer is another organization here in Austin that can help team up patients with a support person who's also been through similar things. Wonders and Worries helps with children whose parents are going through difficult illnesses. Austin Cancer Rehab is an organization here in town that has a lot of exercise classes and nutrition classes and acupuncture. we at Texas Oncology, we have physical therapy and amazing social workers. And I also encourage people to seek out the Texas Oncology Foundation. They have a good Facebook page. And through the Texas Oncology Foundation, yearly, normally, in non-COVID times, we have a Survive and Thrive Survivorship Symposium that all breast cancer survivors and all cancer survivors can go to and get a lot of good information. And it's a good way to build community. This year, we're doing it online, and we call it a Survive and Thrive camp. Actually, our latest one just started. We had our kickoff last night. So I encourage you to go to their, refer patients to their Facebook page for a lot of good stuff there. And I think that is all I had. So, and I'm just 2 minutes late. So this is a great time for questions. We are all here to answer any questions that you may have. Thank you for participating today.
Thank you, Dr. Hudson. These were all three amazing presentations. So we are open for questions and answers, and I do have a few questions I wanted to share with our presenters and give them an opportunity to address. The first question that someone asked is, were all the women in the focus groups in active treatment?
No, they weren't. Some women were 10 years out from active treatment, or as much as 10 years out from active treatment. So it really was a range. There were some in active treatment and some that were not.
Another question we had to do with resources in Houston area. And I know that I don't have the answer to other resources in Houston specifically, but if anybody has any ideas, this is your chance to tell our attendees of any similar organizations to BCRC or any kind of support services in Houston area.
There's the Rose in Houston, which is active in supporting women with breast cancer. I think the Komen group is pretty active in Houston too. There are probably some others that are specific to African American. Sisters is a great organization, which is a national organization, but it's founded in Houston. Dia de la Mujer Latina is a Latino group in Houston that's also national. So some of those are available. Dia de la Mujer Latina also provides community health workers as navigators, and they're trained in breast cancer and other areas of navigation. So that's a few resources.
Thank you, Deborah. That's amazing.
And I would just add, I think a lot of you all would know this, but MD Anderson has a very extensive survivorship service activities of various kinds, programs for survivors. They've also done with, I think, funding from the Cancer Prevention Research Institute of Texas. They've done a number of programs, particularly to try to encourage physical activity. And many of those have been directed at what have been traditionally underserved groups.
Thank you, Heather. Another question we have is, do you think that because women are younger, experiencing this health crisis, that their inexperience within the healthcare system plays a role in their survivorship experience?
That wouldn't surprise me at all. If you think of the average person who's particularly in their 20s, they probably haven't had a lot of experience with the healthcare system. It's been, maybe an annual checkup of some kind, and maybe not even that. So I do think that understanding kind of how to navigate the system, this is where older cancer survivors who maybe have other conditions that have kept them, have taught them, for want of a better word, how to cope with our somewhat fragmented healthcare system are an advantage over our younger cancer survivors. So I would agree with that.
Thank you.
Yeah, I especially find that that's true with insurance or navigating the financial world. A lot of young people haven't really had co-pays before, or spent a lot on healthcare. So it's a huge shock, especially if they have their insurance on the exchange, or of course if they don't have insurance. That is a very rude awakening, which is really unfortunate.
Yeah.
Yeah, and
Thank
I would also add, I think one of the other things that makes it complex for that age group is if you think about where they are in their professional or work life, they're at a time where many times people are switching jobs, and when you switch jobs, that affects your insurance oftentimes. So we were hearing stories from people who said when there were programs that you had to indicate what your income was to qualify for certain kinds of services or support, it would be based on some job that they left or something like that. So it gets really complicated for them because many of them are at a period in their lives where they're kind of, their employment maybe isn't as stable again as an older cancer survivor, or many older cancer survivors are retired. So it's just a very different situation that they're living in.
Mhm.
Yes, I agree. And don't forget, BCRC navigators can help women kind of look at their summary of benefits and help tease that stuff out. And of course, the financial navigators at all of the practices can do that as well. Another question we have has to do with culture. So in the needs assessment or in practice, have you noticed any connection with culture and specific needs and specific decision-making tools that they use, that people of different cultures use, and how does that impact their breast cancer treatment plans, or how, and how do you address those kinds of needs?
I'll say a little bit about this, but I think Dr. Hudson probably has some good ideas from a provider standpoint. One of the things I think that we have to always be aware of is that concern. Are we getting the same information? Are we getting the real information? And I don't know if you remember, but on this one of the slides that I had, there was a person who said, we have to dig for, and it was an African-American woman, we have to dig for information. We have to push to get the information. And so I think sometimes on the provider side, as I mentioned, there's concern about not bringing things up that they don't think people can afford, but that's probably not our decision to make for them. So I think that sometimes there are issues that have not been brought up to people in the past. So it's not so much that they have a different decision-making style, it's just that they are very cognizant of needing to be sure that they are getting all the information.
Mm-hmm. Yeah, I think some cultures, but this isn't necessarily limited to a specific culture, but some people, some cultures tend to have more of a community, close-knit community, where people are more likely to pitch in and help take care of a survivor going through treatment. And so I think that helps a lot. It helps a huge amount. And that's one reason that this year has been so hard, because of COVID, people are not able to do that as much. And then I think in other cultures, maybe some survivors are less likely to, complain or want to tell you about certain problems, maybe like sexuality, for example. So it's just another reason why it's important for us to always ask and not expect patients to bring up certain concerns.
Yeah, I would really agree with that, because I think that was something that came through in the Hispanic focus group, was that sometimes people are reluctant to push their providers for information or push back in any way against a suggestion about a certain treatment option. There's a sense of respect. And so they don't sometimes ask. And so what the navigators were saying was one of the things they try to do is work with women to make them understand that it is, it's fine to ask questions.
Mhm.
So I think you're absolutely right, Dr. Hudson. I think that puts more of the burden on the provider to be sure that they are the ones bringing these things up.
I think the other area is when we look at decision making. I think Dr. Hudson brought this up, is that in some cultures, primarily more you'll see it in Latino and Asian cultures, it's a family decision. So that the woman may defer to her husband or even to her mother or mother-in-law on some of the decisions, and it's not necessarily driven by a financial need, although it may sometimes be, but also it's just cultural that those types of decisions about healthcare are not an individual decision.
That's a really good point.
Wonderful information to have. Thank you. Thank you. Well, I want to wrap it up. If there are any more questions, please Be sure to, you can reach out to Molly if you have questions, and we can ask the presenters any questions you may have that you might have been a little shy to ask today.
And
I want to,
thank you, Rayanne and Molly, for allowing us to participate and share. It's really been a great opportunity.
well, you guys are amazing. We're so delighted that you, our presenters, shared your expertise and your knowledge and your time with us today. And we're really excited for the people who were able to participate in this webinar and watch your presentations. I do want to say our sincerest thanks to Dr. Heather Becker, to Dr. Deborah Volmer-Daki, and of course to Dr. Catherine Hudson for sharing all this information that went very, very fast. But you guys have all been a wonderful, really champions for this project, and we are so grateful for that.